Welcome to Trio Maryland's April Zoom meeting. I'm Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. We'd like to welcome all our members and guests this morning and thank you for attending. Today's topic is creepy viruses in transplant recipients. Our next meeting is on Saturday, May 10th, and the topic is going to be Sun So Bright, Gotta Wear Shades. All about dermatology and skin cancer, so don't miss out. And now I'm going to turn the meeting over to Michelle to introduce the speaker.
Good morning. We're really so fortunate to have today's guest speaker, a personal and fan favorite, Dr. Seema Steinke. Dr. Seema is a clinical assistant professor in the Division of Infectious Diseases at University of Pittsburgh Medical Center. She is also a telemedicine faculty member for ID Connect. Prior to moving to Colorado, along with her military husband and joining University of Pittsburgh, she held a joint appointment as assistant professor in the School of Medicine and in the School of Nursing at Johns Hopkins University for 6 years. Her clinical focus includes transplant and oncology infectious diseases, providing infectious disease care for oncology patients as well as solid organ and bone marrow transplant recipients, and providing telemedicine care to various patient populations across the country. Her interests include multi-drug resistance bacterial infections, transplant infectious diseases, oncology infectious diseases, antimicrobial stewardship in the immunocompromised patient population, and telemedicine care for transplant patients. Dr. Seema attended the University at Buffalo for medical school, completed her residency training at Tufts Medical Center, and subsequently completed her fellowship training at UCLA, where she also earned a master's in clinical research. In her free time, she enjoys spending time with her husband and dog Pebbles, who's so cute, knitting and traveling. We're very fortunate to have Dr. Seema address the Trio Maryland community. Welcome back. Thank you for presenting to our group. And now I turn the program over to you.
Okay, thank you. Can you hear me okay? Wonderful. So I'm talking about creepy viruses and transplant recipients. Just an outline and some objectives for today's talk. We're going to discuss the history of herpes or creeping viruses, identify the common herpes viruses seen in transplant recipients, review the role that each herpes virus plays in transplant recipients, and summarize treatment and prevention for each herpes virus. So let's talk about the history. It has a very long history dating back millennia. It originated and evolved in Africa. And the name herpes comes from the Greek word to creep or crawl, which refers to their spreading nature when on the skin. And just to put a disclaimer out there, I will be showing you some pictures of some of these skin infections. So it may be a little graphic at times, but I tried to pick pictures that were not super graphic. So hopefully it's not too bad for you to see, but you will see some of this creeping effect that the virus has in some of these pictures. Hippocrates in ancient Greek times described lesions that could have been caused by herpes viruses. So we have descriptions of this virus even dating way back when. Emperor Tiberius was a Roman emperor from AD 14 to 37, and he actually banned kissing in Rome for a period of time because of a cold sore outbreak. And herpes was not actually found to be a virus until the 1940s. So even though we have these descriptions dating so far back, it was actually not discovered and identified until the 1940s. And original treatments for herpes viruses emerged in the 1960s, but it wasn't until 1998 that the FDA approved the primary treatment, which is acyclovir. So what are the herpes viruses? They are cold sores and genital herpes is what we commonly think of, but there are many other viruses in the herpes family. We have herpes simplex virus 1 and 2, which cause cold sores and genital herpes. Varicella zoster virus, which causes chickenpox and shingles. Cytomegalovirus, which uniquely causes infection in transplant recipients. Epstein-Barr virus, which is mononucleosis or mono, and post-transplant lymphoproliferative disorder. Human herpes virus 6, 7, and 8 cause roseola infantum and Kaposi's sarcoma. And then there's many, many others, but these are the ones that we are going to focus on today. So some background information on herpes viruses. Because of impaired immunity in solid organ transplantation, herpes virus infections are more frequent, severe, and prolonged than in those with an intact immune system. Key characteristics of herpes virus infections is that they establish latency in the body. In other words, they hibernate in the body and persist for life. So after we've been infected the very first time, these viruses tend to live in various parts of our body, to include things like the nervous system, lymphatic tissue, things of that nature, and it stays there for the rest of our life and can have the potential to wake up. So waking up from hibernation or that latency frequently causes infection, and we call that waking up reactivation. So primary infection means you were being infected with the virus for the first time as a transplant recipient is frequently very severe. So whether you're talking about primary infection or reactivation is actually important to know for the types of syndromes that we see in transplant recipients. CMV or cytomegalovirus causes more than half of the viral infections in transplant recipients. And then herpes simplex virus and varicella zoster virus are the next most common in transplant recipients. So let's talk about herpes simplex virus 1 and 2. HSV1 is most commonly acquired during childhood, usually from oral secretions. About 62% of the population has this infection hibernating in their bodies. HSV2 is sexually transmitted. About 16% of the population has this infection hibernating in their bodies. So, how do these present? Usually as herpetic lesions, they present as painful red blisters that progress to a cluster of smaller blisters. These small blisters are called vesicles. They are fragile and they rupture, resulting in erosions on a red base that usually cross over. And healing may take 4 to 6 weeks without treatment, and in those who are transplant recipients because of a weakened immune system. We often see atypical presentations in transplant recipients because of the suppressed immune system. So sometimes it's even hard for us to tell what exactly it is just looking at it, and we may require a biopsy to make that accurate diagnosis. So orolabial lesions, which are lesions in the mouth and around the mouth, account for most of the HSV1 disease after transplantation. Anal and genital herpes usually results from HSV2 reactivation. Can be complicated by the development of meningitis, which is usually self-limited. In other words, it usually comes, causes bad symptoms. That's usually when you present to the hospital. And then thankfully, it just kind of resolves on its own with supportive care from the physicians at the hospital. So this is a picture of an orolabial lesion. So this is what we think of when we classically think of cold sores. And then this is more severe. This is on the left-hand side, you can see the tongue with severe herpes lesions. And then the picture on the right is actually the esophagus when we do an endoscopy. So that esophagus has those lesions as well. You can see the white kind of shaded areas that are a little raised. Those are all herpes lesions in the esophagus in a transplant patient. This is something called herpetic whitlow. It's when you get herpes on your hands. It's often from touching the ones on your mouth. And then this is eczema herpeticum. This is in a child, but you can see it in transplant recipients. So you can see here how they were small little blisters that have opened and have kind of crusted over. This one is in the healing phase, but it can be pretty bad and painful. So HSV infections from one and or two can spread to other organs such as the lungs, the liver, and the GI tract. This is associated with a high mortality. It's often difficult to diagnose and can be lethal. Lung involvement is more common in lung and heart-lung transplant recipients. In that case, we usually see fevers, cough, shortness of breath, low oxygen levels, and chest x-ray abnormalities. Spreading of HSV1 or 2 to the liver, lungs, adrenal glands, GI tract, and skin can occur during the first 30 days after transplant. And this is a more common phenomenon that we see in kidney and liver transplant recipients. The mortality rate for untreated HSV hepatitis or infection involving the liver in transplant patients is about 60 to 80%. And approaches 100% of blood clotting abnormalities occur. Rapid diagnosis and early treatment are essential for survival, and a liver biopsy is often needed for diagnosis. So let's talk about treatment and prevention of HSV 1 and 2. So the primary treatment or the treatment of choice is something called acyclovir or valacyclovir. Valacyclovir is also known as Valtrex, and so many of you may be familiar with this drug because we do tend to give it to people after transplantation as a means to prevent these infections from happening in the first 3 to 6 months after transplant. IV acyclovir is the preferred method of treatment for severe life-threatening infection, and oral acyclovir is simply more convenient for less serious infections. Treatment for oral lesions is at least 10 days, and acyclovir resistance does occur. This is more commonly seen in bone marrow transplant recipients, and usually the most common presentation for resistant HSV is severe, extensive, chronic oral disease. So acyclovir is given as a preventative dose, at a preventative dose, which we call prophylaxis, and this can suppress viral growth and infection in the immediate post-transplant period. This minimizes HSV-associated morbidity and mortality for transplant recipients. So let's move on to varicella zoster virus. So humans are the only known reservoir for VZV. In temperate regions, VZV epidemics used to occur annually in late winter and early spring. So across the US, we used to tend to see VZV epidemics occurring in late winter and early spring. That's when children used to get chicken pox. But the VZV vaccine, which was introduced in 1995, has changed that landscape dramatically. So prior to the introduction of the vaccine, greater than 90% of the population had varicella infection or chickenpox before the age of 20. Now, due to infection and vaccination, less than 5% of transplant recipients have never been exposed to varicella. So that's actually really good. The introduction of the vaccine has certainly reduced the amount of the population that has immunity from actual infection, and now they have immunity from the vaccination. African American race and older age are associated with increased rates of VZV infection. Due to vaccination, as I mentioned, rates of chickenpox has declined. Chickenpox develops as a result of exposure to airborne VZV. So HSV was oral secretions. VZV is airborne. So someone who has it can actually just release it into the air from their oral secretions, and another person can acquire it. Those who have chickenpox are infectious for about 48 hours prior to and 4 to 5 days after the rash starts. VZV also presents as shingles, which we call herpes zoster, resulting in the waking up of hibernating VZV. So it's, again, reactivation of latent VZV. Incidence is 4 cases per 1,000 population per year, depending on age. In those 80 years and older, the incidence exceeds 10 cases per 1,000 patient years. Rare cases of transmission from VZV from the donor organ can occur, especially if the donor had recent chickenpox. So this is more of an issue that we tend to see in pediatric recipients. But again, with the introduction of the vaccine, the rate of actual chickenpox has declined dramatically. And as a result, we tend not to see this happen as frequently as we used to see it. Zoster incidence in transplant recipients, so shingles, zoster in transplant recipients is about 20 cases per 1,000 patient years. It's a higher risk for lung or heart recipients than for kidney and liver recipients. And it's a highly contagious virus. So let's talk about the shingles. So VZV hibernates, or is a latent virus that lives in the nerves. When it wakes up or reactivates, it travels along the nerve root to the skin, where it produces the characteristic painful rash that we all are familiar with when we know people who've had shingles, or ourselves even who have had shingles. So what about chickenpox? So true primary infection occurs in unvaccinated children, occasionally diagnosed in adult transplant recipients. This is very rare, but it can happen still. And your VZV antibody status, or something we a serostatus, determines clinical decision-making and prevention strategies. So before the availability of treatments, lung and liver involvement was common in transplant recipients with chickenpox. This resulted in a 10 to 20% mortality. Availability of effective antiviral therapy has reduced mortality to less than 5% in transplant patients with chickenpox. So this shingles usually occurs later post-transplant, unlike HSV, which occurs early post-transplant. Prevention strategies with acyclovir has delayed the VZV onset until a median of 7 months after transplant. So as I mentioned earlier, we tend to give prevention with acyclovir for 3 to 6 months. And that is the reason why we don't see VZV present itself as shingles until 7 months or later. Among patients who survive 24 months after transplantation, about 59% of those transplant recipients will develop zoster or shingles. So zoster can present in one of 3 patterns. This is the skin eruption in a dermatomal pattern. And I'll describe what a dermatomal pattern is in just a moment. But we have the risk of spread to the entire body or more than one dermatome. That tends to be pretty high in transplant recipients. A pain that's often described as a neurogenic pain or the nerve pain, it's usually felt as a burning sensation, will often precede the onset of the rash by a few hours to a few days. Then you can have something called visceral disease, where you have involvement of different organs. So not just the skin, but things like lungs, liver, etc. So there's no skin involvement usually in visceral disease, although that's an uncommon presentation. Generally speaking, we do see skin involvement. So we will see shingles on the skin, and then it'll spread to other organs. It's often difficult to diagnose and carries a very high mortality rate. Presents with fever, severe abdominal pain, nausea, vomiting, and often with GI bleeding because of the involvement of the GI tract. You can have also a subclinical reactivation of latent VZV, where in these cases, people develop the pain that's typical of zoster, that burning sensation, but no skin lesions. We call this zoster sine herpete. So that just means zoster without the rash. So this picture on the left is a picture of primary VZV infection. So this is normally what we think of when we think of chickenpox. And then it lays dormant in the nerve roots, and then it travels out the nerve and comes out later on in life or with immune suppression in a single area. That single area is called a dermatome, and that's considered reactivation of VZV. So now, what are dermatomes? These are maps that physicians and nurses use to determine the dermatome of involvement. So dermatomes are the area that nerve root supplies. So in other words, if you have, let's say, L4, that's the nerve root for L4 coming from your back, and it travels down and around the front of your leg here. And if you have shingles in L4, you will have it in that pattern, in that distribution. Similarly, there's also dermatomes on the head and neck, and depending on which dermatome is involved, we know which nerve root the virus came from. So these are pictures of dermatomal shingles. The bottom picture is a picture of dermatomal shingles. The top is also one, but it's one involving the head and neck. And in this particular case, the one up top, you can have involvement of the eye itself when it involves this particular dermatome. And that can lead to things like blindness or just severe vision loss for a temporary period of time. This usually requires the assistance of an ophthalmologist to treat as well, because they inject or put special drops in the eye to prevent the virus from causing the vision loss. So the appearance of classical varicella and zoster can be diagnostic. So if you see a particular rash that looks pretty consistent with that, that can be diagnostic enough. But sometimes in transplant patients, the presentation can be atypical, and distinguishing between the two viruses, HSV and VZV, can be rather difficult. So in that case, we may need biopsy or other laboratory tests to be more certain as to what the diagnosis is. Acyclovir or valacyclovir is again the treatment of choice. Intravenous acyclovir for severe infections, oral acyclovir for less severe infections. Prevention with acyclovir can prevent both HSV and VZV, and again, this is generally given for 3 to 6 months post-transplant. What about post-exposure prophylaxis? So for VZV, we actually do have this. So those who have never been exposed to varicella and undergo transplantation, if they're closely exposed to a VZV person, so either chickenpox or shingles, and by closely exposed, I mean usually a household member, they should receive the varicella zoster immune globulin, something called Varizig. It's essentially pooled antibodies against VZV. So it's like getting a blood transfusion, but that blood transfusion, instead of being red blood cells, are antibodies that we use to fight the VZV. It does not prevent illness, but it greatly reduces the severity of illness. And a single dose will prevent widespread infection in the transplant recipient by about 75%. And it provides 4 weeks of passive immunity. It's usually given within 96 hours of exposure, but no later than 10 days after exposure. And you can use standard intravenous immune globulin, IVIG, if Varizig is unavailable. You should also give prevention with acyclovir or valacyclovir. So let's talk about chickenpox vaccination. So Varavax, it's a live varicella vaccine, and we do not give live vaccines to transplant recipients. So it's usually safe and effective when given prior to solid organ transplantation. Usually we give 2 doses of the vaccine administered at least 2 to 4 weeks apart and completed about 4 weeks before transplantation. Household members who have not been vaccinated should also be vaccinated to minimize exposure to the transplant recipient. So there's a few different shingles vaccines. One is Zostavax. This is a live vaccine. Oh, sorry, I missed a slide. Nope, I guess I didn't. Zostavax is a live vaccine, similar recommendations as to Veravax. So since it's live, we don't give it to post-transplant recipients, but we can give it to pre-transplant recipients in that couple of months before the transplant is to occur. Shingrix, however, is another shingles vaccine, and that is not a live vaccine, and it can be given to those 19 years and older who have a weakened immune system. So if you need to be protected further against shingles after transplantation, you should receive Shingrix because that is not a live vaccine, and therefore it is relatively safe for post-transplant recipients. So let's move on to cytomegalovirus. So CMV is a virus that's found everywhere. In the US, 50% of the population has been exposed to this virus. In the world, anywhere from 30 to 97% of the population have been exposed to this virus. Initial infection with the virus is generally without symptoms or presents as a self-limited fever. Usually in children and young adults. It can present as a mono-like illness as well. So if you remember mono growing up, this can look like that. And we'll get into mono in a little bit, but after the initial infection, the virus lays dormant in our bodies in lymphatic tissue, spleen, and other organs. During times of immune suppression, such as organ transplantation, this virus can wake up and cause infection. So CMV infection or disease is associated with a risk of organ failure and patient death. CMV infection is defined as the presence of CMV actively growing in the blood, regardless of whether or not signs or symptoms are present. CMV disease, on the other hand, is the presence of CMV actively growing in the blood, but there's also the presence of some clinical signs or symptoms. So CMV syndrome is active CMV growth, but with symptoms that are present, but without organs being affected. Whereas tissue invasive CMV disease is CMV growth with symptoms and with organs being affected. And the organs that can be affected can include colon, small bowel, liver, pancreas, kidneys, lungs, eyes, and central nervous system. So if we have gastrointestinal disease, we usually have diarrhea, nausea, vomiting, difficulty swallowing, abdominal pain. This is actually one of the most common presentations, especially in kidney transplant recipients. Hepatitis, which is infection involving the liver, we will have elevated liver enzymes. Often you will appear jaundiced and you'll have abdominal pain. Pancreatitis, the most common symptom is abdominal pain. Pneumonitis, or infection involving the lungs, you'll often have cough or shortness of breath. And then meningoencephalitis is infection involving the central nervous system. Though at that time, you may have headaches, stiff neck, confusion, altered behaviors, or even paralysis. Retinitis is infection involving the eyes, and you may have changes in vision at that time. Nephritis is the kidneys, and you may have change in kidney function, decreased urine output, blood in the urine. Nephritis is actually most commonly seen in kidney transplant recipients. So what are some CMV risk factors? The primary risk factor for CMV infection or disease is the CMV serostatus of the donor-recipient pair. So in other words, the serostatus is the presence or absence of antibodies against CMV. If present, it means that the person has previously been exposed to CMV at some point in their life in the past. The serostatus can be positive, which means antibodies are present, or negative, which means antibodies are absent. The pairs can be donor positive, recipient negative. This is the highest risk group. Or you can have donor positive, recipient positive, donor negative, recipient positive, or donor negative, recipient negative. And that's actually the lowest risk group for CMV. So prevention strategies include universal prophylaxis or preemptive therapy. Universal prophylaxis is administration of an antiviral medication to high-risk patients, beginning within 10 days of transplant and continuing for 3 to 6 months. Valganciclovir, or something known as Valcite, and letermovir, also known as Previmis, are the drugs of choice. Preemptive therapy is monitoring for CMV growth in the blood at regular intervals, so usually weekly, and then valganciclovir is started when the viral growth is detected at a particular threshold. And what that threshold is varies by transplant center and by the test assay being used. Surveillance after prophylaxis is a combination of the above two measures, and it's the less commonly used preventative method. In 2018, the International Consensus Guidelines on the Management of CMV and Solid Organ Transplantation has determined that universal prophylaxis for all of those who are donor positive, recipient positive, donor negative, recipient positive, and donor positive, recipient negative is the way to go. So valganciclovir is started in the immediate post-transplant period. For those who are donor positive, recipient negative, they receive that valganciclovir for about 6 months, whereas the other two groups receive it for 3 months. Preemptive therapy for the low risk group, the donor negative, recipient negative. So in this case, we monitor for CMV replication weekly for 3 months following transplantation. These patients actually receive medications to prevent HSV and VZV, so they get either valacyclovir or acyclovir. Prophylaxis is also often used when a patient is treated for rejection. So if there's a bout of rejection and it gets treated, we will often restart the clock in terms of how we give prophylaxis and our monitoring regimen. So again, for CMV, HSV, and VZV, prevention is vital. So acyclovir and valacyclovir prevent HSV and VZV, and at very high doses, you can have some CMV prevention as well, but that's not a usually well-tolerated dose. Ganciclovir and valganciclovir prevents CMV, HSV, and VZV. So if you give that for prevention of CMV, you are also gaining prevention of HSV and VZV. Letermovir prevents CMV, but not HSV or VZV. So if you give letermovir, you have to also give acyclovir or valacyclovir with the letermovir. So let's move on to Epstein-Barr virus. So this usually infects the entire human population and persists throughout the lifetime of each human. It's the prototypical human tumor virus, strongly associated with the development of a wide variety of cancers to include things like Burkitt lymphoma, Hodgkin lymphoma, and lymphoproliferative disorders, including post-transplant lymphoproliferative disorder. Transmission occurs primarily by saliva exchange, and that's why when we have younger people getting mono, we call it the kissing disease. EBV infection is almost universally acquired in early childhood and is usually without symptoms at that time. When it is symptomatic in a young, healthy population, it often causes mononucleosis or mono, and that can be characterized by things like fever, fatigue, maybe a mild rash. Sometimes the spleen gets enlarged temporarily with mono. EBV after solid organ transplantation, however, the primary infection with EBV is very common in the D plus R minus patients. So again, that serostatus pair matters. So thus the donor is the most important source of infection in this setting. Most transplant recipients are either infected with EBV pre-transplant or they may experience primary EBV in the early post-transplant period. EBV is commonly associated with post-transplant lymphoproliferative disorders, where immunosuppression from anti-rejection medications increases the risk of many types of cancers, including those associated with infectious agents. The overall incidence of PTLD after solid organ transplant is about 1 to 5%. So what is PTLD? It is a spectrum of lymphoproliferative disorders and refers to abnormal overgrowth of cells of the lymphatic system. So what is the lymphatic system? It is made up of white blood cells, and there's two types of lymphatic cells that are involved in PTLD, T cells and B cells. 85 to 90% of PTLD arise from B cells, whereas 10 to 15% of PTLD arise from T cells. So this is just a pictorial representation of the B cells and T cells and what they tend to do for functioning in our immune system. So Epstein-Barr virus is the most commonly associated viral infection with PTLD. 60 to 70% of B cell PTLDs are associated with EBV infection. 10 to 40% of T cell PTLDs are associated with EBV infection. And there is an increased risk of PTLD among EBV negative recipients and EBV positive donors. Kidney and pancreas kidney transplant recipients has an incidence of PTLD that has two peaks, or something that we call bimodal. The initial peak occurs in the first year post-transplant, and that's considered early PTLD, whereas the second peak occurs in the 8th to 10th year post-transplant, and that's considered late PTLD. Accurate risk stratification for PTLD allows for close monitoring of those at high risk and early intervention. EBV plays a major role in the development in almost all early and many late PTLDs. Those recipients at risk for primary EBV infection experience a 5 to 18-fold greater incidence of early PTLD compared to R+ recipients, so recipients who have antibodies. Transplant recipient age is an important determinant of the risk of PTLD. It actually has a U-shaped distribution. So generally speaking, those less than 10 years and those greater than 60 years old are at greatest risk of PTLD development. So what is the PTLD clinical presentation? It is a disease that has a presentation that is often very nonspecific. So fevers, weight loss, fatigue, and large lymph nodes, compression of surrounding organs due to a mass. And all of this non-specificity actually delays the diagnosis. Diagnosis is often made with imaging and biopsy, and it presents on imaging as a new mass or as enlarged lymph nodes. PTLD may actually involve the transplanted organ itself in about 50% of the cases. And it can be detected early by monitoring EBV blood levels. So here is like a schematic that we tend to follow for detecting PTLD early. So you can see here in the middle of the screen, the onset of iatrogenic immunosuppression. That just means the onset of the transplant. And when we give suppressive medications to suppress the immune system, you can see here that the green line and the red line show these little bumps. You can have this happen pretty frequently where you have little blips or just little bumps in the EBV level, but it's not until you see this persistent rise where we start to worry about PTLD. So if we see this rise and once every week we check the levels and it's continuing to go up and up and up, that raises our concern for having PTLD develop. So EBV serostatus should be determined in all donors and recipients before transplantation. In D+, R- transplants, immunosuppression should be minimized as much as possible, and preemptive monitoring is the preferred PTLD strategy. So that graph I showed you where we're monitoring it at a regular interval, that is the preferred PTLD prevention strategy. Antiviral drugs have activity against EBV in the lab, but this does not play out in humans due to the way EBV resides dormantly in the body. So all the drugs, acyclovir, valacyclovir, ganciclovir, valganciclovir, and some other drugs we have not yet talked about, foscarnet, cidofovir, brincidofovir, and maribavir. They all have some activity against the virus in the lab, but again, it doesn't play out in our bodies. So the role of these antiviral drugs in PTLD is controversial. Many see no effect on PTLD and therefore do not administer it. So this is just a schematic of how a certain group of physicians who wrote this article treat PTLD. And I think the main takeaway is that, you know, you might have some findings considering PTLD. And then what we normally do is reduce immune suppression. And if really bad, we give something called rituximab. You can have relapse PTLD. It's rare, but it can happen. And then one of the things to take away from this slide also is that PTLD is potentially life-threatening in solid organ transplant recipients. So it's imperative that we make that diagnosis and treat as we need to treat to try and prevent it from getting worse. So let's move on to the last group of viruses. This is human herpes virus, or HHV 6, 7, and 8. All three have been discovered since 1986, and all three play a unique role in disease in immunocompromised patients. HHV 6 primary infection is usually acquired during the first year of life. Saliva is the most likely mode of transmission. HHV 6 persists in the host as a latent virus, and the prevalence in healthy adults exceeds about 90%. 38 to 55% of kidney transplant recipients develop HHV 6 infection, and 22 to 54% of liver transplant recipients develop HHV 6 infection. 36% of heart transplant recipients develop HHV 6 infection, and up to 57% of heart-lung transplant recipients develop this infection. So what is its clinical presentation? So HHV 6 infection usually occurs between 2 to 4 weeks after transplantation. You can have direct or indirect effects resulting in a variety of symptoms. So direct effects, you can have a skin rash, nonspecific fevers, bone marrow suppression where your white blood cell count or your platelet counts may drop low, and it can cause encephalitis, which is infection involving the brain. And then you can have indirect effects where it may facilitate infection with other organisms, especially CMV. And HHV 6 is also an independently significant predictor of developing fungal infections in liver transplant recipients. So this is a picture of primary HHV 6 infection. This is something called roseola infantum. So you can see the red rash on the baby's skin. This is very characteristic of HHV 6 primary infection. So what about prevention and treatment? Acyclovir and valacyclovir actually does not have activity against HHV 6, but rather ganciclovir and valganciclovir do. However, studies are inconsistent with regards to its efficacy at prevention. For treatment, ganciclovir and another drug called foscarnet have been successfully used. Foscarnet and cidofovir are treatment modalities for when this causes central nervous system infection or encephalitis. So let's move on to HHV 7. Primary infection usually occurs in childhood, but at a later age than HHV 6. HHV 7 can also cause roseola infantum, or that picture I showed you of the rash on the baby's skin. This often has been associated with neurologic complications in healthy children, particularly something called acute hemiplegia in childhood, as well as something called febrile convulsions. And it may be a cofactor for the development of CMV disease in transplant recipients. So how do we manage HHV 7? So it's most effectively treated with cidofovir. However, there is some conflicting data regarding the use of ganciclovir for treatment. All right, let's move on to the last one, HHV 8. So this is also known as Kaposi sarcoma herpes virus. The incidence of Kaposi sarcoma herpes virus is widely variable and depends on the geographic prevalence. So US is actually of low prevalence, though we still do see this in immunocompromised patients. It's known to cause a cancer called Kaposi sarcoma. KS or Kaposi sarcoma affects less than 1% of transplant recipients. And KS accounts for 3 to 10% of all cancers in transplant recipients. It generally affects males more than females in a ratio of 3 to 1. So KS lesions in transplant recipients is usually the result of reactivation of the latent virus. However, some donor-derived infections can occur, and KS is one of the earliest post-transplant cancers to occur in transplant recipients. The median time to onset is about 22 months post-transplant. The incidence of KS is higher in liver transplant recipients than in other organ transplant recipients. Clinical presentation: skin is the most commonly involved site for KS, and about 40% of transplant recipients with KS may develop lesions on their organs, including the GI tract, the lungs, the bladder, and the larynx. So this is what KS looks like. You can see here on the left, this is KS involving the skin. You can see this like purplish, reddish hue. These are raised bumps that are very soft and fleshy, but you can also have it involving visceral organs. This is involving the inside of the mouth on the right-hand side. You can see his gums have been enlarged, and up here he has several KS lesions involving the hard palate. So reduction or cessation of immunosuppression remains the mainstay of treatment. However, 50% of those treated with cessation of immune suppression may unfortunately lose their transplanted organ. So in those where KS fails to respond to reduction or cessation in immunosuppression, chemotherapy is often used. Experience with antiviral therapy is rather limited in the transplant setting, and studies are inconclusive on whether antiviral therapies are effective. So this is essentially the end of the talk. So I had a whole bunch of references embedded in the slides, and then I also used this textbook, Transplant Infections, the 4th edition, for some background information. So thank you for your attention. Let me close out of this and come back to here. All right, I'll stop sharing.
So you do have some questions. You have,
Okay.
if you want to look through them, or if you want me to read them to you, whatever you prefer.
No, I can read through them.
Super.
Is there a way to get rid of BK virus? I need a second transplant. But they will not do the transplant until the BK is not seen. So BK virus is a very unique virus to kidney transplant recipients. It is a very difficult virus to treat. The primary way to get rid of BK is to reduce your immune suppression to as low levels as possible, to try and minimize the amount of BK that is present by allowing your own immune system to take over and kill the BK. But that's the only effective way to get rid of it. I think that, there's some therapies out there, but they're not proven to be effective for treatment of BK. That is the proven method of treatment, is reducing immune suppression. How do you know this started in Africa? So when they did studies looking at the molecular strains of these viruses, they were able to trace it back to animal reservoirs in Africa. And where on the continent? That I don't know. I'm sorry. If someone has taken a live shingle vaccine, should transplant recipients maintain distance or stay away from them? Yes, especially if they develop a little spot where the injection of the vaccine was given. So they can get a little, it looks like a little mini spot of shingles or chicken pox. Actually, it just looks right where the injection is given. You might see a small bunch of vesicles there. If that happens in particular, it is imperative that the transplant recipient stay away from that individual for at least a couple weeks until that vaccine has subsided in their system. Let's see. What is the treatment protocol for CMV patients with D plus R minus after the 6-month treatment window with Valcyte has expired? That's a really good question. So after 6 months, we usually resort to monitoring. So we check levels in the blood periodically every so often. So usually most centers do weekly to monthly, somewhere in that frame. But we check those levels regularly for another 6 months or so to make sure that it doesn't rise. And if it rises, then we start therapy with Valcyte before it becomes an issue. I'm 17 years post-heart and double transplant recipient, and what I remember is my donor was positive for CMV and I am negative, so I'm considered high risk, taking acyclovir since I had my transplant, 200 milligrams twice a day. Yes, it is absolutely okay to take acyclovir for long periods of time. That being said, I have seen resistance develop, but it's been mostly in patients who don't take it regularly or who take it at a dosage that is lower than what is required for their kidney function. So, in other words, if you take too low of a dose for what your body needs, you can develop resistance. So generally speaking, resistance doesn't develop if you're taking the correct dose and you're taking it as prescribed. Is there a blood test to see what viruses we have been exposed to? This would help our doctors. Yes, we run these blood tests on all transplant recipients. Prior to the transplant, we run the tests to make sure that, we know exactly what the donor and the recipient have been exposed to so that we can do the necessary prevention modalities appropriately. Should we know our DR status pre or post transplant? Yes. I think knowing the more information transplant recipients know, the more power you have to talk with your physician and understand the care that's being provided. So I am an advocate for knowing as much information as you possibly can. If you don't know what it is, you can talk to your transplant coordinator and they will be able to tell you exactly what it is. Should transplant patients receive any type of booster after the initial 2 doses of Shingrix? I believe you do not need any boosters, but if you do, that would be a decision you would make with your transplant physician. If you are having just a difficult time mounting an antibody response to the vaccine, it may be beneficial to get a booster after 5 or 10 years. Is the Shingrix vaccine then safe for liver? Yes, it is safe for transplant recipients because it is not a live vaccine. Okay. I think those are all the questions.
Dr. Seema, this was very detailed and very good. Anyone that needs to re-see this presentation because of the details, you will receive the link to the recording in about a week. So you can always go back and look at a section that you might need to revisit. But thank you again through all that you're doing with moving and all of that. We so appreciate you being here today. Thank you.
And
Of
please
course.
thank Mr. Pebbles for getting up so early this morning with you.
I will.
We want to thank everybody for attending this morning. We love seeing your smiling faces. Remember, check out our events page on our website for advance notices of future meetings. And check out our website, www.triomaryland.org. All of our past meetings are posted on the YouTube channel for your convenience. And we wish you a great weekend and a lot of new sunshine next week.
This is great. Good seeing everyone. Those that we can see. Have a good weekend. Bye, Dr. Seema.
Bye.
Bye, Dr. Seema.
Thank you.
Bye, Mr.
Bye.
Willis.